Welcome to Care Transitions Today, Case Conversations, a podcast presented by the Association of Physician Leadership in Case Management and the American Case Management Association, where we dive deep into the world of healthcare case management and transitions of care. Today, we are joined by three physicians, Dr. Rebecca Severe, Dr. Sweta Singh, and Dr. Teresa Jacobs. Dr. Rebecca Severe is a hospital medicine certified physician serving as medical director of care management for Advocate Aurora Health. With a focus on utilization review, quality management, and program leadership, Dr. Severe is passionate about evidence-based medicine and collaborative patient care. Her expertise and commitment make her a valuable asset to the medical community and a compelling voice in the podcast. Dr. Sweta Singh, Medical Director of Case Management at the University of Michigan Medical School, brings a wealth of experience in hospital medicine and a strong focus on quality improvement and patient safety. Her dedication to medical education and commitment to enhancing healthcare make her insights invaluable to listeners eager to learn and grow in the medical field. Dr. Teresa Jacobs is a clinical professor of neurology at the University of Michigan and is a distinguished expert in neurocritical care. Her wealth of experience in teaching and research brings invaluable insights to our discussion surrounding a variety of intricate case scenarios. In this series, we'll explore the challenges and triumphs of real-life case studies, providing valuable insights for healthcare professionals and anyone interested in the intricacies of patient care. Whether you're a seasoned physician advisor, a dedicated case manager, or simply someone passionate about improving healthcare outcomes, Case Conversations is your go-to resource for compelling stories and expert insights. This is Care Transitions Today, Case Conversations. Today we have selected two intriguing cases to discuss.
Well, thank you guys. I've got a case here, and Teresa, given your neurology background, I'll appreciate your input on this. So this patient is an 87-year-old. It's a Medicare Advantage patient, presented to the emergency room with slurred speech, some dizziness that was present when the patient awoke. At 11 o'clock at night when the patient went to bed, the patient had no symptoms at that point in time. So that was the last well-known time for the patient. In the emergency room, the NIHS score was a 2. The head CT was negative. The CTA was negative for any large vessel occlusion, no aneurysm, no stenosis. The patient was then admitted to the floor for further monitoring and neuro workup. So they did start this patient out as inpatient. The patient on hospital day 1 was able to get that MRI, and it did show a small foci of acute ischemia in the right cerebellum. There was no hemorrhage. There was this ovoid area in the left parietal region, but there was no edema, mass effect. They felt that maybe this was a cavernoma or a sequelae of a prior microhemorrhage. Now, in hospital day 2, they did an echo. There was no thrombus. The bubble study was done. The lipid panel was done. The usual stroke, TIA sort of workup with lab were done. The neurology did note on their exam the only abnormality was some mild spastic dysarthria. They did opt to get some bilateral lower extremity Dopplers. The bubble study was positive. I forgot. I said that wrong. So they did opt to check some bilateral low extremity Dopplers to rule out a paradoxical embolism. That was done in the afternoon in hospital day 2. And then hospital day 3, they had ongoing the PT, OT, and speech therapy evaluations with a recommendation for home health. So we did get a denial on this case. So I'll pause there and see what each of your thoughts are on how you would handle this as the PA. If you would go for the peer-to-peer, or if you would choose to just rebill it at this point in time.
This is a great case, Rebecca, because we often face these TIAs or small strokes, and everyone feels like we should be able to get this all accomplished in 24 hours, and therefore it doesn't meet criteria. But what you're talking about here is an elderly patient who in fact did have imaging results that showed that she had a stroke. And you had a TTE study with a positive PFO, and you had to do the next step, which was to see if there was any clot that could have caused paroxysmal emboli. And admittedly, you have this cavernoma. I'm not going to say, I don't see the imaging myself. But in my mind, it definitely speaks to the fact that perhaps that could have been an old area of infarction that may have been because of the PFO. So personally, I would have called this an inpatient, and I would have stated it as this is an elderly female who has had a stroke and required a workup for that stroke, which led to a further workup for paroxysmal potential for causation of stroke in light of both a positive bubble study and other imaging findings on the MRI scan. And I would have continued to consider her to be at an inpatient level of care because of that for greater than 2 midnights at 87 years old.
Yeah.
Sweta, what would you say?
I agree with that, especially if we have evidence of, with the MRI, proving it's a stroke and not just a TIA, and all the care needed, even if this was a shorter length of stay, say it didn't go over 3 days, we have a very efficient system and it was taken care in less than 48 hours or in 2 midnights or less. I would have still argued that the complexity, the medical necessity is high in these cases and the risk is high, that this is appropriate to be as an inpatient level of care. And so this was denied and there was a peer-to-peer. I've done peer-to-peer for similar cases too. So I'm curious to know how was your experience, and then I will be happy to share what was my experience in those peer-to-peer.
Sure.
Can I say one more thing about the case,
Sure.
Rebecca, before we go forward? The other thing that I didn't mention is that here's a patient with a cerebellar stroke, which will give you a spastic dysarthria, which is probably not life inhibiting, but PT and OT are definitely needed because the cerebellum I'm wearing my neurologist hat here. The cerebellum is important for how we carry out motor function and whether or not we are going to be able to handle ADLs or if we need some care regarding the ADLs, and speech regarding whether or not there's any dysphagia that goes along with the cerebellar stroke. So I would add that into to the whole issue. And then I'll let it go back to answering Sweta.
So, and one more question. Is there Q4 neurochecks ordered?
I believe so. It's standard. Our standard, protocol would include those. So yeah, I didn't, double check, but just knowing that we have our order set that includes those, it should have been in place for this patient. So I think both of you brought up some good points, and I think Teresa, you kind of hit on what ultimately helped me with this particular peer-to-peer, because what I found, more recently since 4201, when I'm having, discussions with our, MA medical directors, is that you really have to prove that there were no delays in care, that there was, a reason that you couldn't get them out after that first midnight. And so as I was digging into this one, it was just with the notes that I could see, I was looking at hospital day 2, and I was wondering, I'm like, why could we not get her out? I know she was older. I saw that we didn't actually have the PT, OT, and speech therapy evals completed that day. So I was trying to understand why didn't they happen? Because if there's any hint of a delay on our part, that can, I'll get pushback from that medical director, that we could have gotten him out after 1 midnight. So I did reach out to the clinician. This was a retro denial. So I reached out to the clinician and said, help me understand what was going on hospital day 2 that did not allow you to discharge that patient. Was there more going on? Why couldn't you send her home? And this patient actually had some additional symptoms that were not captured in the notes. They were dizzy, as you pointed out. It was a cerebellar stroke. And so I think she had more clinical symptoms, still persisting. And I do find when I'm dealing with a stroke, if I can establish they have persistent neurologic symptoms on hospital day 2 and beyond, that too can help support inpatient. Because oftentimes if it is a stroke but behaves more like a TIA where those symptoms are completely resolved, I do find that I struggle more to get those overturned with a paramedical director. So it was worth it for me to reach out to the attending and get that bit of information about the ongoing dizziness. And, to help substantiate why they couldn't get the PTOT. And I think because we kept that patient pretty busy with tests on hospital day 2, and there were notes in the chart of therapy trying to come see patient. But at the time they showed up, patient was getting her various tests during the day and being seen by neuro, for example. So I was able to get this one overturned. So I don't know, Sweta, how was your success for your similar cases?
Pretty much, like you said, showing the symptoms and the challenges and in taking care of these cases, as well as the other thing that care provider has asked me is if we have any new medication, new antiplatelet or new statin initiation, high dose. And those have helped me as well to make an argument for an inpatient and proving that it's not just the simple, straightforward TIA, but someone who needed to come into the hospital.
Teresa, any other neurologist thoughts on this one?
I absolutely agree that I think this patient is definitely an inpatient. But whenever I'm looking at these cases, when I'm reviewing them as the PA, I do try to look at it too from the perspective that perhaps it is a TIA, and a TIA can be in an observation status and not actually require inpatient care. So I try to be very careful about being sure that if I'm saying I think it's an inpatient and deserves a peer-to-peer, that in fact it meets the medical necessity and falls outside of what would be considered, the 2 midnight necessity. So I just step back to say sometimes not all neuro problems meet inpatient criteria, which is hard for me to do because I see the patients afterwards and understand that all of the laborious concerns they have that require time and effort, the questions and concerns about antiplatelet therapy, the questions and concerns for this patient are going to be, what are the prolonged treatment for a PFO, et cetera. So that would be my only thing to say is sometimes you got to step back and say, is it really inpatient? I don't have any problem with calling this one inpatient, but I would just make the generalized statement that sometimes TIAs or even small strokes can be observation level status.
Yes. Okay. Well, thank you both for your comments.
The Association of Physician Leadership in Care Management, or APPLCOM, was created to provide support and education for physicians in this field. APPLCOM is unique because of its connection to the American Case Management Association, focusing on the partnership and collaborative model of nurse case managers, social workers, and physicians in care management. ACMA has a rich 25-year history of supporting the case management field. AppleCom is inclusive of all practice settings. Membership in AppleCom also gives you access to all ACMA resources and benefits. Whether you're new to case management or have years of experience, AppleCom membership is valuable. Gain access to professional networking opportunities and resources. Visit www.applecom.org to learn more. Case managers. Join thousands of your peers who have made the decision to further their connections, learning, and knowledge through ACMA membership. Access the Member Education Center with recorded webinars, CEs, and peer-reviewed articles 24/7. Visit www.acma.org/membership to learn more. Let's continue with our second case.
I'm going to go ahead and transition to my second case, which I'm going to put out there at the start of this, and we'll talk about it a little bit more at the end of this case. But This second case is also a Medicare Advantage case. It is actually the same payer as the last case. And this particular case, we've got another, elderly female. She's also 87. And this patient was presenting with an untreated lymphoma. Patient came in for generalized weakness, multiple falls. They were actually found down for an unknown amount of time. And in the emergency room, the labs revealed that this patient had hypercalcemia. It felt likely to be secondary to the malignancy, as well as a component from some dehydration. And she did have some AKI, as well as an elevation of her troponin. And so the calcium on presentation was 14.2, corrected to 14.6. Troponin mildly elevated, 120, or repeat at 144. And then the creatinine was at 2.08, with a baseline for this patient between 1.27 and 1.67. CK mildly elevated at 1,000. And this patient was also hypothermic at 95 degrees Fahrenheit. She was started on IV fluids at 150 cc's an hour, given some IV Lasix to help manage the calcium. She was also bradycardic in the 40s. So cardiology was consulted, an echo was ordered, a TSH was mildly elevated, and so they adjusted the levothyroxine. So that was all hospital day one. So pretty busy hospital day one. I think lots of, abnormal numbers, a number of interventions. So then we get to hospital day two for this patient. The calcium, again, when we corrected it for albumin level, it was 12.7. Her creatinine was still above baseline at 2. They opted to continue this patient on normal saline at 150 cc's per hour. They started her on oral Lasix 20 milligrams daily. And they had an echo that cardiology had ordered because of the bradycardia, and it showed that her EF was only 42%, and she was akinetic to dyskinetic at the apex. Now, this was a new finding, but the last echo was done in 2015, so they, couldn't really say, the acuity of that, akinetic portion. Now, she did go ahead and stay that second midnight. So on hospital day 3, the calcium corrected to 11.1. The creatinine was close to her baseline at 1.73. They were still continuing the IV fluids at 150 cc's per hour, but did cap them at about 8 o'clock that evening. And she had a CT done this day as well to evaluate the lymphoma. And she was it did show increased lymphadenopathy. It also now showed, unfortunately, some volume overload because she was getting 150 cc's per hour and her EF is only 42%. She stayed another midnight. So, that was our third midnight. Hospital day 4, corrected calcium was at 11.7. The creatinine was now on baseline at 1.64. And that they ultimately did end up discharging her later that day. But we did get a denial on this case. So I'm going to pause there because I'll just get your thoughts, and then how this played out with the pair was relatively interesting. So I'll let you guys tell me what are you thinking right now in terms of appealing it, the appropriateness of inpatient.
I think the patient is appropriate from inpatient from the first day. And when I was listening to the story, I was like, please don't tell me that the pair denied this. How can anybody deny this case, right? AKI, hypercalcemia, someone with lymphoma who could be tumoralizing too. And then along with that, it's not recovered after the first midnight. They've been IV fluid continued beyond second midnight, and patient actually stayed 4 days, 3 midnights, 4 days. So there was continued care needs on the third day. A lot of times pair want to see, okay, first 48 hours are observations. So what happened after that? There were still things happening, and IV fluid, CT, further planning, how to keep the patient out of the hospital. And especially now that all the fluid we have given if we don't take care or figure out a plan for fluid management, someone with a low EF, they'll come back with fluid exacerbation. So it's extremely important to take that also into account. So I would definitely argue as an inpatient, and if peer-to-peer is an option, would argue like say we should take this for peer-to-peer discussion.
Yeah.
I absolutely agree with everything Sweta has said. If peer-to-peer is an option, I would take it. If it's not an option, then I would fight this denial with an appeal. And again, you have a patient whose span of illness here is great. If you defined the problem initially as this patient's got hypercalcemia, the admission was to fix it, you fixed it by day 3, voila, it's done. But there's the complexity here is so much more than just simply the calcium or the acute kidney injury. You've got a patient here who has an underlying disease process that is likely contributing to the reason why they came to the hospital, and that needs to be managed. You also had cardiac concerns here, and you found those out through your echocardiogram. You found the ejection fraction to be low, and unfortunately, fixing the hypercalcemia in the AKA gave you hypervolemia, which then is in fact a complication that we as medical providers may have caused, but the patient's underlying disease processes are what contributed to that. We can't modify that. Fortunately, we are not God, and therefore the patient had to be there a third into a fourth day. I absolutely feel that this should have been inpatient, and I would appeal this every day of the week, Rebecca.
Yeah. Yeah, and so that was my thought. I looked at this case and I was like, slam dunk inpatient, like we just need to talk to the peer medical director. And this was not one that I did the original peer-to-peer on. One of my physician advisors did, and unfortunately they lost the case. And since the 4201 went into effect, one of the things I've been working with my group on is that, I've asked my team to give me feedback. How are the interactions going with our peer medical directors? Are you having any issues, any cases where you feel like the 2 midnight rule is not being followed? Please send them to me for escalation. Because one of the things that we did before 4201F went into place was we went and met with a lot of our big payer medical directors to have kind of a pre-meetings, talk about what they were thinking, establish rapport. And with most of them, we left it as after this goes into effect, we'll likely check back in with you to see how it's going, good or bad, and we'll talk about cases or any concerns. So this came to me through one of my PAs as part of that work that I had done to say, hey, let me know if you're having any trouble. And so when they sent it to me, I was like, gosh, this to me stands out as one that I'm shocked that it wasn't felt to meet the 2 midnight rule. And so we did have a subsequent meeting with our some of our regional payer medical directors for this particular plan to discuss this case and several others that we had where we really felt like there wasn't that consistency and, following the 2 midnight rule. Now I'll say that we are having a lot of cases where for this particular pair where they do follow the 2 midnight rule. Like I said, that first case we had, I felt like it met the 2 midnight rule. They agreed with it. It got approved. So this was one where we wanted to say, hey, why is there this disconnect between us and you on this 2 midnight rule? So I met with the regional medical directors, and the 2 that I met with, they too are like, oh yeah, that's inpatient. And then they started looking at the background details. And unfortunately, this case belonged to a different region. It wasn't their region. So they're like, well, we would be happy to overturn this. We absolutely agree with it, because we had several others in this conversation with them where they're like, yep, we agree with you. Our team should have overturned these. We will give them feedback. We will get these overturned. We agree with you. But this one had to go to a different region. And so but they were nice enough to arrange a discussion for me to talk to their medical director to help understand why they did not feel that this met the 2 midnight rule. And it was a very interesting discussion. This medical director had approached it very differently than what I saw, with our usual in our region. And I just could not get her to budge on this being, appropriate. She really just felt the patient didn't need to be there. Like the calcium, and I kept saying, hey, you have to do the corrected calcium. And I pointed that out, and that is why it was justified in continuing IV fluids. But she really felt like the treatment we provided was not needed, that she got IV fluids. She should have been ready to go. Her creatinine was down some. You should have gotten her out of there. And I don't know, for me, it was just really hard to comprehend an 87-year-old untreated lymphoma. She came in because she was on the ground for a while because she fell. And you have to really, address that hypercalcemia because she's going to be weak and she's going to fall again. And she was also tricky to manage, as we pointed out, because of that ejection fraction. And maybe that troponin, it rose a little bit, a little demand ischemia, going on. Like maybe there was some acuity to that hypokinesis there that, was also, I think, justified. We didn't know how she was going to behave. So I couldn't get her to budge on this one. It was a very different conversation compared to our usual. So that is why I brought this one to really compare and contrast. I'd say for the most part for us, our conversations with our MA plans are going fairly well. I'd say most of them are being reasonable about the 2 midnight rule, but we will get these cases that just, I call them head scratchers. I cannot, we're on 2 different pages with our payers. And so this one is definitely going for written appeal. I don't have an outcome on it yet, but any other thoughts that you guys have or comments on your experience?
I have a question for you, Rebecca. So you'll do appeal, and I'm assuming that part of that appeal will be generating a letter of medical necessity and another discussion. What are your next steps beyond that?
I believe with this, because we don't, as physician advisors, we don't do a lot of the appeals beyond the peer-to-peer. Like occasionally we'll get questions, but we have a whole team of denial nurses that will manage these beyond. So they start with a written appeal, and then I believe it goes to Maximus. And then I'm not sure if this particular plan, we have a level beyond that or not. We might, I'm not sure. But this to me is one that I feel very strongly, if we have any opportunities to go beyond our next level written appeal, to keep going. Like I would say, to my revenue recovery team, this is a great example. It really should be pushed. It's not a soft, second midnight in my mind. It was very clearly medically necessary. And it went well beyond second midnight. We got to hospital day 4 for her. So.
And I think this case brings up that, again, good point. Bedside providers who are actually seeing the patient, challenging that medical decision making is concerning to me. Like if the patient should be continued or not, or was the appropriate care provided or not. Because to me, like we just discussed, the complexity, the untreated lymphoma, and how to avoid patient from falling again and coming back with the same issue should also be taken into consideration, and thus continue to require care beyond the first midnight. Even if the creatinine improved a little bit, it didn't normalize, that we can argue. And yes, we want to see a downtrending creatinine, and if it's an ATN, it will eventually come back fine, and it's not something we want to keep the people in hospital till they get to their normal or to their baseline creatinine. But this is a different, unique case scenario where I totally agree with you. We need to continue arguing with the appeals, because, and that's again, some of my experience has been too when it comes to the 2 midnight. I feel like some of the peers are respecting the 2 midnight, but sometimes they are fixated on then is the second midnight required, or seeing if the medical care required or not, or fixated on the criteria to define the medical necessity, which should not be the case. And we are collecting those cases to have those discussions, Rebecca, because I think at the end of the day, data is what helps collect, like once we have volume of cases that we can say, here are the representation of cases where 2 midnight was not followed, then it will have a stronger voice. So any institution or hospital that's struggling, I think, keep collecting data. Well, Teresa, do you have any other comments?
No, thank you for bringing the case, Rebecca, especially looking at the juxtaposition of this case with the last case in the same payer and how they treated the 2 midnight issue is very important. And I appreciate that. Thank you.
Yeah,
Thank
no,
you,
and I definitely tell my team to, just go out. If they meet that 2 midnight rule, continue to do your peer-to-peers, continue to be aggressive and make the case for it. And don't let, one case where you couldn't get it overturned start to shape how you handle the cases. So that is one of the things I keep messaging my team too. So, well, thank you both for your comments. I appreciate that. It's always a great discussion. And I think I always learn something new every time I talk to you both.
Thank you to everyone for joining us for another episode of Case Conversations. We would also like to thank Drs. Severe, Singh, and Jacobs for sharing these interesting cases in this episode. We would love to hear from the audience. Please join in on the conversation by visiting acmaweb.org/podcast, and don't forget to subscribe so you're notified when we upload new episodes. Until next time, this was Care Transitions Today, Case Conversations.